On this episode of the Real Life Pharmacology podcast, we're going to talk about angiotensin receptor blockers, also known as ARBs, ARBs. Common drugs from this medication class include irbesartan, which is Avapro, candesartan, which is Atacand, losartan, probably the most common one I see, which is Cozar, olmesartan, Benicar, valsartan is another one I commonly see in practice, which is Diovan, and telmisartan, which is Micardis. The mechanism of action is as the class describes it. So these are angiotensin receptor blockers, and what they do is prevent angiotensin II from binding to the angiotensin II receptor. If you remember from the ACE inhibitors, angiotensin II is a potent vasoconstrictor. Now, there are other cascading events that can happen from this binding to the receptor, and another important one to remember is the release of aldosterone. And by preventing or blocking the release, reducing the release of aldosterone, that can potentially raise potassium levels, which I'll talk a little bit more with the side effects portion. So remembering that mechanism of action, looping it in with ACE inhibitors. ACE inhibitors prevent the production of angiotensin II, which is that potent vasoconstrictor. Angiotensin receptor blockers prevent the binding of that angiotensin II to its receptor. So hopefully that kind of makes sense in how they lower blood pressure and act on that angiotensin II. The most common indication for use for the angiotensin receptor blockers is certainly hypertension. With that said, there's also quite a few compelling indications for using an ARB, just like there are for ACE inhibitors. So a couple of classic examples is heart failure. These medications can be beneficial in that setting, improving mortality. Another setting is in diabetes and reducing the risk of kind of a progressive kidney disease type situation. Memorable side effects from the ARBs. Hyperkalemia, so I remember that interplay with aldosterone. So blocking, reducing the effects of aldosterone in the body can raise that potassium. So a situation in clinical practice where that can be helpful is in patients who maybe are on diuretics already. So let's say you've got a heart failure patient, they're on furosemide, a loop diuretic already. Well, that's got the potential to deplete potassium. ARBs can potentially raise potassium and potentially help with that, along with the compelling indication that I mentioned before. In general, when you think about ARB side effects, think of ACE inhibitor side effects. So they can lower blood pressure, they can cause that hyperkalemia. Now, the one exception to that is cough. ARBs, because they work in a different area mechanistically, do not cause the cough at the rate that ACE inhibitors do. So what this means is in patients that maybe we've got a good compelling indication, we really want to use an ACE inhibitor, but they ran into that cough with an ACE inhibitor, we can certainly try an ARB, and likely, in most cases, they will probably tolerate that ARB without issue. Again, as long as they didn't have other side effects as well with an ACE inhibitor. If it was just that cough, they probably will likely tolerate that ARB. Lab monitoring is going to be important with the ARBs. I mentioned that potassium. Like I said, in situations where this is added, you definitely can run into a hyperkalemia state. The other important parameter we need to monitor, and this is true of ACE inhibitors as well, is kidney function. The way they work in the kidney, they can potentially exacerbate or contribute to an acute renal failure situation. That's more common in the setting of drug interactions, which I'll kind of talk about in the drug interaction sections. But kidney function and potassium are very, very important. And then obviously blood pressure as well is going to be another important monitoring parameter. One really rare side effect that's true of both the ARBs and the ACE inhibitors is angioedema. Incredibly rare. I've only seen it a couple of times in my years of practice. So again, very, very rare. But if you ever hear of a patient who has angioedema, your first thought probably should be, are they on an ACE inhibitor or an ARB? There are other medications that can potentially cause angioedema, but again, ACEs and ARBs are kind of the ones that I've always been most classically taught as contributing to an angioedema. So that swelling of the lip, the mouth, the tongue, and potentially down into the airway is what we get really, really concerned with angioedema about, because that potentially could block off that airway and prevent a person from breathing, which obviously is not a good thing. In the management of blood pressure, one kind of unique pearl with the ACEs and ARBs is that patients of African descent, blacks, may not respond as well to this medication, and that's simply due to kind of genetic variations and the role of the renin-angiotensin-aldosterone system in these type of patients. So an important pearl to remember there in our patients that you may not see responding to these medications. Definitely remember that if they've got African descent or black, they may not get a decent reduction in blood pressure lowering effect. If you really like this podcast, I wanted to point out a book I wrote called Naplex Nuggets. It's really a bullet point study guide for the most highly testable medications and the clinical pearls that are really relevant, really, really important, that frequently come up on pharmacology exams and things like that. So check it out on Amazon, Naplex Nuggets, Naplex Nuggets, and I think you'll find that it's a pretty valuable resource, much like this podcast, in breaking down medications and classes and side effects and really highly testable stuff. I want to finish up on drug interactions with the ARBs. ACE inhibitors and ARBs both generally tend to not have a ton of drug interactions, so that's a really, really good thing. With that said, there are definitely a few. So first one I wanted to mention is lithium. So ACE inhibitors and ARBs, you may see these medications raise lithium levels. So a patient who has bipolar disorder being maintained on lithium, that is a potential concern that we need to monitor and pay attention to. Second interaction I've got to mention is hyperkalemia risk. So if a patient's already on drugs that can raise potassium, so an example being an aldosterone antagonist like spironolactone, for example, if we add on an ARB to that medication regimen, we definitely do increase the risk of hyperkalemia. Now, the drug itself, whether it be a losartan or a valsartan, the drug itself can do it on its own, but we may have a little bit of an additive effect if we use an ARB maybe with a spironolactone. Another drug that I do see used on a short-term basis is trimethoprim, which is commonly found in Bactrim, combination of sulfamethoxazole and trimethoprim. So that trimethoprim component can potentially interact with those ARBs or any other drug that can raise potassium and kind of give it an added boost and significantly bump up that potassium into a potentially dangerous level where we could have EKG changes, cardiac changes, things like that. The last interaction that I think you definitely need to be aware of and monitor is kind of the cumulative effect from multiple medications that can have an impact on the kidney. So whenever we've got an ARB, maybe you've got a patient taking an over-the-counter NSAID for pain. They may also be on diuretics in the setting of CHF, fluid overload, edema, things like that. The more medications that can be taxing on the kidney can kind of have this cumulative effect, and we do increase the risk of acute renal failure as we increase doses and add more of these type of medications. So it's not that these drugs are never used together, because they certainly are. I see ARBs and diuretics used frequently. But when we add more and more of these medications, you got to recognize that we may have to do a little closer monitoring on kidney function and make sure that we're not putting our patients into an acute renal failure type situation. I think that sums up the podcast for today. Hopefully you enjoyed it, find it valuable. I've got a really sweet offer going on where I'm giving away a 31-page PDF, and it's of the top 200 medications, and that's right on the website, reallifepharmacology.com. It's simply for subscribers. You get updates to when I create a new podcast and any type of special offers as well there. So again, 31-page PDF on the top 200 drugs. I pick out 3 really highly testable pearls that are likely going to come up in any pharmacology board exam or things of that nature. So go check that out, reallifepharmacology.com. Take care. Thanks for listening, and have a great rest of your day.